call upon uh, Dr. Tushar Agarwal. He is going to speak to us on the enhanced monofocal, which can be used for the astigmatism. And before he takes over, the experience of the eye surgeon operating the eye surgeon. Those patients, eye surgeons whose age is more than 70, if they are coming to me, they ask for me monofocal IOL. They never ask me for any other IOL. Those who come at the age more than 60, they always say go for the bifocal IOL. And less than 60, I operated only 3, they come for the multifocal IOL. So I think the age also is matters when the ophthalmologists are getting operated. So Tushar.
Yes, sir. Thank you very much, sir. Actually, this talk will actually feel like extension or continuation of Dr. Harbanslal's talk. So I think some of the points which were raised in the last by Dr. Noshi Shroff, I think I might be able to put some clarification on that. Now, okay, slides.
Slide नहीं move हो रहा है. Slide. Ah, okay.
So there is no financial interest in the presentation. Now, why we are bothered about astigmatism is that about 50% of patients present with more than one diopter of astigmatism, and around another 25% fall in the range of 1 to 1.5 diopters of astigmatism. And as cataract surgery itself has become partly a refractive surgery, this has become more important to treat at the time of cataract surgery. And it's important because up to around zero 0.5 diopters of astigmatism, it has minimal to no effect on the visual acuity of the patient. Most patients will have 20/20 visual acuity. However, as the astigmatism inches up higher, even a 0.25 jump from there starts to play on the UCVA, and 1.5 diopters or more will have a significant impact on the uncorrected distance visual acuity. And this is why we now try to deal with astigmatism along with cataract surgery. So there are various modalities in vogue. Incisional modification, it was relevant when the incision sizes were more than 2.8 millimeters. At that time, an axis phaco could deal with low degrees of astigmatism, but with now 2.2 incisions, which are astigmatically neutral, that axis phaco doesn't work. Then you have techniques like arcuate keratotomy and LRIs, especially now with femtosecond. These are a good option to treat, again, low to moderate degrees of astigmatism, but the reliability is not as great as toric IOLs, which are now the gold standard or the standard of care for managing any type of astigmatism with cataract surgery. Another choice is a staged corneal excimer procedure. It is very effective in treating any kind of astigmatism post-operatively, and it will also take care of any refractive surprise or even surgically induced astigmatism. But of course, it requires the second surgery, which most of the people won't like in cataract surgery. A couple of words about toric IOLs. They are very predictable now in correcting very high degrees of astigmatism also. They are very reliable. There are no additional incisions required. However, they do induce extra steps in the operative workflow. You need extra machines for preoperative workup, intraoperative use as well. Then there is always a risk of rotational instability, especially in the initial curve. Some patients may require rotation of the lens in the postoperative period. Then there is a logistical challenge also, that some patients with very small pupils, patients with BPH, corneal opacities, you may not be able to accurately place the toric IOLs, and surgeons may be wary of putting toric IOLs in such patients. So the current talk stems from a couple of papers which were published around 3 years back, which presented the results of the enhanced monofocal lenses or the EDOF lenses. These terms are used interchangeably, but Vivity, for example, is formally called an EDOF lens. IHANS comes under the category of a premium monofocal, not an EDOF, because as Dr. Lal pointed out, the range is slightly less than Vivity. So, and a corollary of these studies was that they found that they postulated that somehow the astigmatic tolerance was slightly higher than monofocal lenses, And we hypothesized that the reason could be that how these lenses are made to function. Monofocal lenses have a single plane of focus. The so-called multifocal lenses like Restore in the past, they were actually bifocal lenses, which had two planes of focus. But the EDOF lenses or the enhanced monofocal lenses have a slightly elongated plane of focus. And this is how they work. So this again, coming to our old textbook knowledge of Sturm's conoid and how astigmatism affects vision. So if you have a monofocal lens, you will need a pinpoint focus at a particular plane to achieve 20/20 vision. But how the EDOF lenses work is that this plane is actually enlarged in both directions, and that is why you achieve a slightly extended range of vision with these lenses. And this was the hypothesis that we wanted to test, that whether this can actually also accommodate for the slight amount of refractive error induced by low degrees of myopia. So we studied a group of patients, 19 each, in which they had 0.75 to 1.5 diopters of myopia. We selected this range, which was the starting range for where we start putting toric lenses. Below this, we normally avoid toric lenses. And both sets of patients underwent bilateral cataract surgery sequential, and in one group we used an enhanced monofocal lens, and the other an equivalent standard monofocal lens. So what we found was, so we analyzed the results both binocularly and uniocularly. I'll explain the reason a little later. So in terms of binocular UCVA, the results were similar. The enhanced group had slightly better vision post-operatively at all follow-ups, but all of them did not reach any significance at any point. They did, however, show a significantly higher, better unaided near visual acuity. And this is the curve, I think, which Dr. Harbanslal was also referring to, that we found that there was a significantly better defocus curve. So you will find that up to point, so what this lens, just to simplify how to interpret this, is that an enhanced monofocal lens will allow you a slightly, it will tolerate a slightly higher degree of spherical equivalent in the post-operative period. And this actually allows for the higher range of vision to develop. And this was found to be significantly higher, which we expected in the post-operative period. The contrast sensitivity was also higher in the enhanced monofocal group. Now, we also tried to differentiate between patients with the on the basis of just not on the logmar visual acuity, but on the basis of how many lines of vision which they have, and this is where the two lenses separated in terms of the results. Almost 50% of the patients with the enhanced monofocal lenses had 6/9 or better vision binocularly, whereas only about 10% of patients with monofocal lenses had this vision. Then we separated the groups further into two subgroups. The first group which we took was only up to 1 diopter of astigmatism, and the second was 1 to 1.5 diopters. And again, here we found that almost 85% of the patients had 6/6 or better vision when they were implanted with an enhanced monofocal lens, whereas only about half of the patients with a standard monofocal lens had 6/6 or better vision. In the higher astigmatism group, you will find that the results became similar, almost similar in both groups, where we found only 70% of patients had 6/6 or better vision, as compared to 42% in the standard monofocal group. So to summarize the results, at 3 months, binocular visual acuity in the group ranging from 0.75 to 1.5 diopters, there was no statistical difference. However, they did show a better unaided near vision, better intermediate vision, and better higher contrast sensitivity. And when you talk about the subgroup of 0.75 to 1 diopters, almost 85% patients achieve 6/6 or better vision without the need for any toric lenses. So I'll conclude my talk here. Toric lenses remain the standard of care for managing any degrees of astigmatism along with cataract surgery. However, enhanced monofocal lenses seem to be a viable option, especially in patients where the astigmatism is 0.75 to, so that's the exact narrow zone where these lenses may be helpful. because less than 0.5, we as such do not use any toric lenses. We start to use toric lenses once the astigmatism goes beyond 0.5. So in the range of 0.5 to 1 diopter lens, these lenses seem to provide a very good uncorrected distant visual acuity. However, these results need further validation. This study was done at the time when IHANS was available and the IHANS toric hadn't come. Now the IHANS toric. So the ideal comparison now, which I think we would plan, is a head-to-head comparison between IHANS toric and IHANS in these patients with the low degrees of astigmatism. Thank you.
Tushar, thank you. It was a self-explanatory, and so that we will not take question answers, we are getting late. So Dr. Mal Fernandez is there. Dr. Fernandez, okay, please. So she is going to speak to us on the pediatric cataract, what to do and what not to do. Dr. Fernandez. Now we can take Vanhati till before that. Vanhati, you come here and start your presentation. I will miss up.
afterwards ना इनको टाइम लगेगा तो you can take question.
नहीं क्वेश्चंस नहीं लेना, उसको करने दो,
लगा रहे हैं ना
शुरू
12
करके
के
लेट हो रहा है. ठीक है, ठीक है.
can be ready. 1 can be ready. Yes. Question दे दो ना कब तक निकाला.
ठीक है. हाँ.
Tushar, I want to ask a question to Tushar that what is the experience of yours with any other EDOF lens compared with the enhanced monofocal lens?
So as we were speaking, so we do use Vivity also, but as suspected or as you pointed out, there is not much of a difference in terms of the near ad required. So both lenses, in most patients, you will find the patients reach about N8 vision. And they do require an ad of 1 to 1.5. Though I haven't formally studied the two lenses in terms of the near ad required, but my sense is that both require 1 to 1.5 diopters of near ad for reading fine print. So I, I
Any more dysphotopsias with the VVT lens, because that's got a bump in the center, whereas these enhanced monofocals are almost they have a aspheric surface or anterior surface and therefore no bump or no this thing. So does that cause any dysphotopsia?
Sir, my experience with the two lenses, so it's almost about a 75-25 ratio, 75 in about 75% IHANS and 25% Rivety. But I haven't seen any IHANS absolutely. But so the weight of experience is 3 times that in Rivety. But I haven't seen any photopic phenomenon with the Vivity